What do I think of weight loss surgery? I guess I haven't given it much thought. I guess if it makes people live happier, healthier, more comfortable lives, then go for it.
Well, for me, it could go both ways. Like, there's a good and a bad thing. If you knew you could make a change with your body, like, I don't think it's necessary to have surgery to lose weight. But let's say if you're like you can't lose the weight, like you're stuck in bed, then I'd definitely say that's an option.
Oh, I don't know heaps about it. I hope it's not happening because people are feeling pressure.
If you have the money, you have the money. You may as well take it. Cosmetically, it's questionable. I don't know if it's ever going to actually solve anything, but there are some weight zones that require, for medical purposes. But yeah, I think if it's cosmetic, it's a quick fix, and then it needs a diet or lifestyle change to really cement any proper weight loss.
Kia ora. I'm Sasha Borissenko, and welcome to Chewing the Facts. In this series, I hope to untangle some of the science, history, assumptions, and forces behind fatness in Aotearoa. Could everything we know about weight be wrong? Or at least more complicated? In this episode, Going Under the Knife, I'm going to delve into weight loss surgery. You might have heard terms like stomach stapling in the past. That's now been replaced by more advanced and effective procedures called bariatric surgery. They're essentially operations that reduce a person's stomach and can alter their internal plumbing, if you get me.
A Christchurch surgeon is urging New Zealanders to stop going overseas for bariatric surgery. A Kiwi mother was left fighting for her life with sepsis after undergoing weight loss surgery in Mexico.
Surgery for morbid obesity. So this is a whole field in surgery, bariatric surgery, medical and surgical treatments for weight loss, really reserved for the top of that triangle for people who need to lose more than 100 pounds of weight to really protect their lives and increase their health.
For the health profession, it's been posed as a solution to the obesity epidemic, and yet it's riddled with issues around who can get it and what hoops they have to jump through to prove they're worth spending health dollars on. This is a hard one, because for some, this is seen as a cosmetic procedure or quick fix. For others, this life-changing operation is a last resort. It also has wider ramifications for the fat population. And just a warning, this episode discusses eating disorders, mental illness, and some gory medical stuff. This is Sophie. It's not her real name. She wants to remain anonymous, so we've distorted her voice as well. She had bariatric surgery 10 years ago.
I carried a lot of weight around my belly. I had high blood pressure. I had diabetes. I had risk of infection and kidney failure and all of those. The small blood cells in the kidneys get attacked by the blood sugars. I couldn't get my blood sugars under control. I went through periods where I would do exercise 3 times a day, and I'd try and diet, and I would lose a little bit of weight, but I really wouldn't lose much.
In 2013, Sophie was one of 450,000 people worldwide who had bariatric surgery that year. But let's rewind for a moment. There are 3 main types of bariatric surgery. There's the gastric band, where a plastic ring is put around the top of the stomach. Fluids can be put in the band to make it a bit tighter, but they're not common in Aotearoa, as the bands have been shown to move around and erode. Weight loss is traditionally less pronounced too. Next up is the gastric sleeve, where a tube the size of a vivid marker is inserted through the mouth to mobilise the stomach. Then, about 80% of the stomach is removed, so it looks like a narrow tube. What's left behind is about 1/3 to 1/2 of a measuring cup.
And I'm going to add 3/4 cup of sugar. I'm using this instant or super fine sugar because you want to be sure that the sugar melts. That just gets beaten around till it gets a little bit thick.
But we're not baking here, folks. On average, people lose about 65% of their excess weight, meaning, say you're 100 kilos and your ideal body weight is 60 kilos. The 40 remaining kilos would be your excess weight. So 65% of that is 26 kilos. Finally, there's the gastric bypass, which is considered the gold standard internationally. It's been shown to have the most dramatic and sustained weight loss among patients. The stomach is cut in two, and one portion, which holds about, again, a third of a measuring cup, is attached to a piece of the bowel. What's left behind is the rest of the stomach and about a metre of the small intestine. They're not just swimming in there, they're then attached further down the literal pipeline. It sounds pretty brutal. For Sophie, it was. Her health did have some improvement eventually, but it was by no means an easy fix.
So unfortunately, I went in for surgery on the 26th of March 2013, and right from the outset when I woke up, I was vomiting blood. I had a nasal gastric tube, which you have, and you have a drain coming out your side, and so if anyone thinks that surgery is the easy way to lose weight, they really need their head read, because it's not. It's actually pretty brutal. Because what they do is they cut away 80% of your stomach and leave you with 20% along a line. And your first thing that you do is wake up with a nasal gastric tube, which is pretty horrible. And then the next day they make you drink barium while you've got a nasal gastric tube to check that you don't have any issues with the surgery. You get x-rayed with this tube in your mouth and down through your nose and that, and you feel pretty revolting. But I never stopped feeling revolting, so once I'd taken the tube out and I went home, I started vomiting blood. And within 2 weeks I was back in hospital because I had a gastric stricture, and so basically the line that they'd stitched was too tight. My stomach now, having had imagery done, is twisted, so I now have about 15% of a stomach, and it also doesn't function quite properly. So it's twisted. It's a bit like an hourglass. It's got a bit up the top where food sits and then it gets stuck. So if I don't eat the right food, like if I eat red meat, etc., I'll vomit it back up. I'm in a good place where I can eat probably about 1,500 calories a day, but at one point it was like trying to get 700 calories a day into me was a nightmare. I nearly died.
Singer Lisa Marie Presley's cause of death just revealed. According to the Los Angeles County Medical Examiner, the 54-year-old died from complications from a prior weight loss surgery. The report says it was, quote, a small bowel obstruction caused by scar tissue that developed after a previous bariatric surgery years ago. The manner of death is natural.
Here's Mark Grant. He's a bariatric surgeon based in Otago. He performs both public and private surgeries and says there's a risk with bariatric surgeries, sure, but they need to be looked at in context.
With any intervention, you can have death as an adverse outcome, but in the scheme of things, people still think bariatric surgery is high-risk surgery. But actually, the gallbladder surgery is one of the commonest operations that bowel surgeons will do, and that carries a mortality rate of about 0.5%, and which is one of the commonest operations we do in the public hospital, and no one bats an eyelid at it. Whereas when we do bariatric surgery, it's on par, if not less than gallbladder surgery, the mortality rate associated with it, or the complication rate associated with it. And we've got very much better with our anaesthetic support as well.
So people think bariatric surgery just restricts the amount of food you can eat, but it's the hormonal and physiological changes to your whole plumbing system that's the real kicker. Gastric bypass is pretty complicated. I'll hand you back to bariatric surgeon Dr. Mark Grant for this one.
But when you're eating that, you're not absorbing anything, because actually you need the liver enzymes and the pancreas enzymes to be mixed with food to enable you to break it down. And so in that first portion of your bowel, which is about 100 centimetres, you're not absorbing anything. And so the gastric bypass works by, one, restricting how much you can eat, and two, it's got a malabsorptive component or a hypoabsorptive component, which means you don't absorb food. But because we've reconfigured your bowel, other hormones change too.
Here's the wild thing. These surgeries not only limit the amount of food, they also alter the entire biochemistry of the stomach and intestines. It means people will have a decrease in appetite, their metabolism kicks better into gear, and it's shown to help people with type 2 diabetes. Now, type 2 diabetes is a disease where the pancreas can't make enough insulin, or it doesn't use it properly. Insulin is a hormone that breaks down glucose in the bloodstream. Over time, it can lead to heart disease, vision loss, kidney disease, and organ failure.
This story of insulin is told you by two men whose experience and authority in this field is unique. On your right is Professor Charles Best, who with the late Sir Frederick Banting discovered insulin. In fact, did you actually discover insulin?
It's a little difficult to fix an exact date. It was toward the end of July, 26th or 27th of July 1921, when we first saw the dramatic lowering of the blood sugar of a dog when we gave it an extract from pancreas that we thought was potent.
We know diabetes is associated with age and weight, but the science is out as to whether it's the cause. In fact, a 2012 study found mortality rates were twice as high for people in the normal weight range than those classified as overweight or obese using the body mass index. Remember, the BMI is a basic tool used to measure fat by dividing a person's weight in kilograms by height in metres squared. And we know it's inaccurate. Think muscly all-black rugby dudes, for example. We also know it's problematic, particularly for people of colour. Studies show diabetes has a strong genetic component. There have also been links to sleep deprivation, low income, urbanisation, and it disproportionately affects Indigenous people. Science is increasingly looking at the links to sugar, too.
Myth number 1, only overweight people get diabetes. This couldn't be further from the truth. While weight can play a role in type 2 diabetes, genetics, lifestyle, and other factors also contribute. Thin people can develop diabetes too, so it's essential to focus on overall health rather than just body size.
Here's Emma Thomas. She's an eating disorder clinician and has a psychology and commerce background. She explains the difference between association and causation.
Okay, so I'm just looking at your dress, Sasha. So people who wear brightly coloured clothes are more likely to be extroverts. So I could conclude that wearing brightly coloured clothes changes your personality into an extrovert. Most people are going to think that's pretty stupid. More likely it's probably the other way around, right? That actually extroverted people are more likely to wear brightly coloured clothes. So obviously that's massive oversimplification. But we can't draw conclusions until we actually know. And the research doesn't show that fatness causes disease. It shows there's a correlation. And now there's even research showing that it's not the fatness itself, it's the social determinants, it's socioeconomic status. I think the medical system has so much to answer for. The medical system has failed fat people at every turn. I think it's a scapegoat. It's easy to understand, and the reality is it's those social determinants, it's genetics like correlation, not causation. So, if people that are predisposed to diabetes are also predisposed to being in a large body, we don't actually know that. We don't know that large bodies cause diabetes. We just know that there's a correlation between large bodies and diabetes. So that doesn't conclude that fatness causes diabetes.
What does happen, though, is the more weight a person's carrying, it means the pancreas has to do more work to get insulin around the body. So weight loss is often advised.
Hi, I'm Wilford Brimley, and I've had diabetes for about 20 years. I stay active and I feel pretty good most of the time. See, I do a few simple things now. I'm not perfect, but I try and watch my diet and exercise, and I check my blood sugar.
But we know that people with a body mass index of more than 30, chances of attaining a 5% reduction in body weight is 0.001% for men and 0.01% for women. So, going under the knife is seen in the medical community as a great option for people suffering health conditions that are associated with fatness. We're talking 60 to 80% of bariatric patients have successful outcomes. In a statement, Te Whatu Ora Planned Care Clinical Lead Derek Sherwood said, "Within days of bariatric surgery, patients will have reduced appetite, and those with metabolic syndrome or type 2 diabetes will automatically go into remission. This occurs before obvious weight loss."
The two most common ones, called sleeve gastrectomy or something called a gastric bypass, both are the gold standard in prolonged, permanent, sustained weight loss and improvement in diabetes, high blood pressure, high cholesterol, sleep apnea, that occurs actually instantaneously after the surgery, that have nothing to do with the weight coming off.
So, this tidbit presents another spanner in the works for the widely accepted view that fatness or weight equals diabetes. Along with surgery, new weight loss drugs, which tackle the hormonal element, have been pegged to turn the entire system on its head. Semaglutide, which is commercially known as Ozempic or Wegovy, is an injectable diabetes medication that also induces drastic weight loss. It was first approved in the US to treat diabetes in 2017.
People with type 2 diabetes are excited about the potential of once-weekly Ozempic.
The drug lowers blood sugar levels, regulates insulin, and imitates hormones that are produced in the intestines. Okay, so these hormones make us feel full and prompt the stomach to empty at a slower rate. It's also been praised for its ability to reduce alcohol consumption and obsessive thinking about food. There are risks, though, including malnutrition, facial aging, nausea, and unwelcome plumbing issues like diarrhea. And, like bariatric surgery, it exposes social tensions between addressing illnesses associated with fatness and fueling fat stigma. Ironically, the diabetes medication has been such hot property that there have been international shortages.
Scroll through TikTok and you're sure to see Ozempic. Some now calling it the skinny pen, a drug developed to treat diabetes that's become known for its side effect, weight loss. But there's another side effect to its soaring popularity, shortages. And now diabetics are calling out people just using it to drop a few pounds.
This year, the country's regulatory body, MedSafe, approved Ozempic to be prescribed to treat diabetes. It's not publicly funded, so Australian and US prices suggest it could cost anywhere between $100 to $1,000 a month. It's a case of furthering the divide between the haves and the have-nots. Back to hormones and Mark Grant again.
Within the top of the stomach is a hormone called ghrelin, which is an appetite hormone. When you're hungry and haven't eaten for a while, it's produced by your stomach and your duodenum. It tells the brain, come on, let's go and eat some more food. And then when you've eaten some food, it's not the stomach distending as such, but further down in the small bowel, there are receptors that respond to firstly carbohydrates, then protein, that tell you've eaten too much. And then ghrelin goes down and then you stop eating. You've lost your appetite.
This was the case for Sophie.
I never felt full, so that was a weird thing. So I, as a kid, would go to parties and stuff myself stupid with food. And I come home and vomit. And I had no stop switch. And people can be really judgmental and they go, well, she's just fat because she eats too much. Well, The truth was, when I went to the sessions before I had the gastric sleeve, and they said to me and the group that were there, some people don't have a gene that makes them feel full. They literally don't. And that after they've had this surgery, they come and hug us and cry, which is what I actually literally did, and say, oh my God, for the first time in my life, I know what people mean when they say, oh, my clothes feel tight and I've eaten too much, and they know to stop. And that was my experience. It was like I could eat half a plate of food and go, actually, I don't feel like I need it anymore, or I don't need to eat anymore.
Mark Grant says all of the surgeries have their pros and cons.
Bypasses come with a downside, is that you can get problems whereby, because the pouch is so small and the joint is a fixed area, that things can get stuck. So people can get food intolerances. Some people will, I've got patients who've happily drunk water all their lives and suddenly had a bypass, and actually they don't like water and have to have it with flavoured things. With bypasses, people can get problems with bread, stringy meats like chicken, if it's not chewed really well, just because the pouch is small and it can get stuck. Whereas with a sleeve gastrectomy, because you've got the pylorus, which is the mouth of the stomach, if you like, or the exit of the stomach, which is just a muscle that opens and closes, you can still probably eat a normal meal, so you don't get as many food intolerances. And you certainly don't get a condition such as dumping, which is by, if you take too much sugar on board or have processed food with a bypass, sugar gets presented to your small bowel far earlier than it normally does, so people can get loose bowel motions. Or you can, if you've had really sugary food, your blood sugars go up really high, and then your pancreas produces insulin to bring your sugars down, but it just overshoots, so then you can get sweaty, tachycardic and pass out, which is very rare.
In fact, 85% of gastric bypass patients can experience dumping, which is a term used to describe extreme bouts of diarrhea. This wasn't the case for Sophie, but eating has always been tricky. She went from eating a teaspoon of yogurt and jelly twice a day for 6 weeks. 10 years later, food is still a struggle.
You know, you go to a restaurant, you pick a tapas restaurant because you can just pick at things, but there's social stuff around food too that's quite hard. I found that I would still, or at a friend's, place for dinner, still fill my entire plate up like I would when I had like my full stomach and ability to eat, because then no one asked questions about why you were eating so much, and you sort of just try and eat a little bit. You're at a restaurant and they go, is there something wrong with the meal? And you go, well, and you don't want to tell them, I've had a gastric sleeve operation.
Mark Grant says weight loss will be most pronounced in the first 6 months after the surgery, with people on average losing about 1 kilo a week. After 9 months, there will be a bit of a plateau, but weight loss will continue up until the 18-month mark. In some cases, the surgery doesn't work. A Swedish study in 2004 found 9% of gastric bypass patients and 25% of gastric band patients gained much of the weight back within 10 years of the treatment. Here's bariatric surgeon Mark Grant again.
But even in people who've been successful for 18 months to 2 years, some people can put the weight back on again. And that's because surgery is just a tool. And most surgeons will keep saying that actually I'm just a cog in this world. The dietitians and psychologists are really important. Because even if I give you the most perfect bariatric procedure, if you choose to go and have a thick shake, if you choose to go and have calorie-dense food, and lots of it, small amounts regularly, you will put the weight back on again. Because it's all about energy expenditure and energy intake.
Here's Kylie. She's a university contractor. She had the gastric sleeve in 2008.
You said that you went from a size 28 to a size 18 in 2 years, and now you're a size 26. And you used the words that you failed at it. What do you mean by that?
Well, I failed at weight loss surgery. Because, well, initially I didn't, but it's supposed to fix you for the rest of your life.
I mean, the research that I've looked into, it says that, the possibility of weight gain is very much there. There's the trope around putting in chocolate bars into a Ninja Bullet.
Yeah. Or KFC. That was the one I
Right.
always heard, yeah. I just blended my KFC. Yeah.
When, quote unquote, you started to see that it wasn't working, quote unquote, was there a drastic change, or was it just your body just doing what it's designed to do?
I think after 2 years, I felt the worst about my body that I've ever felt in my entire life. I wasn't, filling out my skin the way I had before. Even though I was bigger, I filled out nicely, I was rounded. And now I had all this, like, I felt like an elephant kind of, with the saggy skin. And it freaked me out because I was still reasonably young. And I'm like, this is just going to keep getting worse and worse. And there's no way I'd ever be able to afford plastic surgery to fix this. So I can't let this keep happening. So I stopped being so active, doing so much exercise, because I think that's what was really helping me lose the weight. And I don't know, I just plateaued after that. And then after getting pregnant, I started going back up.
Research shows people hoping to get the surgery have higher rates of eating disorders compared to the general population. It's why psychiatric assessments and continual care are important, Mark says.
The surgeon or clinician will work the patient up to make sure there's no sort of medical conditions that need to be treated and optimised, particularly someone sees they've got poorly controlled diabetes, then you're going to have an increased risk of wound infections or complications. Poorly controlled blood pressure, you're going to have complications associated with that. We actually need to get them fit so they can have an anaesthetic. Once we've done that, they also then see a psychologist, and that's really important because we need to make sure there's no sort of underlying mental health issues that we're unaware of, and as surgeons we can be particularly poor at picking that up. But often within the bariatric population there is a significantly high prevalence of mental health conditions within that, and we need to make sure that that person is not going to be done any harm by going through surgery. We also want them to have a good understanding of what things may change from a psychosocial situation post-surgery.
Up to 60% of potential bariatric patients also suffer a variety of psychiatric disorders, including mood, anxiety, personality disorders, and substance abuse. For Sophie, who's a successful lawyer, she realised the extent of the weight discrimination after the surgery.
I'd been in that workplace 18 years at that point, and what I noticed that was different was, so I went, I left being a big woman and came back 6 months later being like, I'd gone down to 49 kilos at one point, and I think I was back up at about 59, 60, so I was tiny. And back to that workplace, and having men that I'd worked with for a long time suddenly acknowledging me and talking to me and offering to lift boxes and stuff for me that they would have left me to do on my own, and holding the lift open for me, like quite different behaviour, and acknowledging me and talking to me and asking me how my weekend was, and that was quite a shock for me, really. And the trajectory from there of getting promoted, getting better jobs, getting paid more was just like quite mind-blowing in a way, because I'm like, wait a minute, I'm still the same person, I still have the same skill set, I'm still who I am. But even like I was always quite a outspoken, bolshy woman. It's more acceptable when you're a slim, bolshy woman than when you're a fat, bolshy woman that you're almost looked at as, oh, she's gross, she's what a horrible person. So even my behavioural traits that were seen as negative before were not seen the same way. They're just like, well, she's a go-getter.
Even after the surgery, a 2015 Yale University paper found 13% of patients reported an increase in disordered eating, low self-esteem, and depression. The surgery has also seen an uptick in divorce rates. A 2016 study found bariatric patients were 3 times more likely to attempt suicide than the general population. Self-harm increased by 50%. Research has also linked the surgery to alcohol abuse. A 2017 study found 1 in 5 people suffered drug and alcohol abuse within 5 years following the surgery. For those that had no issues with alcohol before the surgery, they were twice as likely to develop alcohol problems. There's the psychological side of things, but also the physiological side of things. One study found alcohol blood levels rose faster and stayed higher longer following gastric band surgery, for example. The financial strain and the stress of trying to meet the grade to get on the operating list is also off the scale. According to bariatric surgeon Mark Grant, the surgeries can cost anywhere between $23,000 and $29,000. Here's Dr. Brian Betty. He's a family doctor and chair of General Practice New Zealand.
If you're carrying a lot of extra weight, with surgery, there is big increased risks that can start to occur in terms of surgical complication, right? So in some of these issues, there's a genuine medical reason we've got to tread very, very carefully. There is no doubt in other cases, and I'll be blunt about it, weight can be used as a tool for constricting access because of capacity issues. And we see that all the time. I mean, one of the tools that's used for bariatric surgery, you have to be, in certain places in the country, you have to be less than 165 kilos. If you don't get to 165 kilos, you can't have the surgery. Now, we know in private, they'll do surgery on people who are 220, 230 kilos. So there isn't necessarily a medical reason for that, but there's certainly a capacity reason as to why that's been put into play. And I think this is particularly tragic when this occurs. Patients who just try so hard, they may be sitting at 175, 178, try so hard to get to that 165. And I've had one patient who's got to 167, missed out by 2 kilos and been told, no, you can't. And it's just felt like an abject, absolute failure. And yeah, really, really destructive, really, really difficult. So I think as a system we operate in ways often that are really, really hard for the patient.
Is this just health rationing, or could there be discriminatory practices here? It gets tricky, as there's a difference between direct and indirect discrimination, noting that weight discrimination isn't in the New Zealand Human Rights Act, but I'll be exploring this more in episode 7. The criteria to have publicly funded bariatric surgery here dates back to 2012.
Bariatric surgery alters your digestive system to encourage weight loss and can cost as much as $25,000 to $30,000 here in New Zealand. But an all-inclusive trip to Mexico for it is almost half the price.
In a statement, Te Whatu Ora said, the prioritisation tool in place helps to select patients who would benefit most by the surgery. The risks of surgery increases once the patient has a BMI of more than 50, and many services have a cut-off BMI of around 55. It goes on to say people won't be considered if they've already had the surgery or if they have other health problems that will impact the effectiveness of the surgery, or if the surgery wouldn't be safe. People with uncontrolled psychiatric conditions wouldn't qualify either, nor would people who have a BMI of less than 35, or if their weight can be traced to steroid use or Prader-Willi syndrome, for example. So, how does it work? You get a score, depending on factors such as a person's quality of life, the likelihood of achieving maximum benefits, and the surgical risks. Then you're placed on a waiting list. In 2021, patients waited an average of 108 days. This increased to 175 in 2022. And those New Zealanders most likely to struggle with making the score are Māori and Pacifica. Here's Ash Gillen, a PhD candidate, research fellow and lecturer at the University of Auckland. Her background is in Indigenous health studies.
We know that even if we think about stereotypes and kind of the ways in which fat brown bodies are talked about, fat Indigenous bodies, we know that that's very much a harmful kind of tool, I guess, so then oppress us further. BMI doesn't really have any positive impact on health, but we still use it. And the health community still use it. It's used in, like, one of the things I find really ironic is it's used a lot in bariatric surgery, which, you know, inherently is, we're going to fix the fat. But if your BMI is too high, you're a bad type of fat person, you don't get access to this fix the fat treatment that inherently would make you a good person. So it's like a double punishment, right, in the framing of it.
Even though it's often reported Māori and Pacific people have higher rates of obesity, it's much harder for them to get the surgery.
It's a heavy burden for Middlemore Hospital. They have 40,500 morbidly obese people in the community, more than double the number of any other DHB.
Studies investigating equity in bariatric surgery for Indigenous peoples worldwide is severely lacking. But an Auckland University study found there were 2,500 referrals to have surgery between 2011 and 2017. 1,050 went on to have the surgery. 40% identified as Māori, 28% identified as Pasifika, and 63% identified as Pākehā. Here's Gary Jackson. He's a public health doctor and the Director of Population Health at Te Whatu Ora. He works out of Counties Manukau, which has the highest concentration of Māori and Pasifika people classified as obese using the Body Mass Index.
I did some work on the original business case for surgery, so in 2008 when it became part of the public system, and we used 0.5% of the BMI 35 plus population was the kind of the target that was set at that time, and that was purely a financial issue, or more than financial and a capacity issue. We didn't have enough surgeons and theatres to do any more than that, and there was a cost in trying to get that cost relativity with all the other elective surgery. We never achieved 0.5% even, mainly because of a capacity issue, getting enough theatres and enough surgeons. I think counties had the highest number. We got the highest number of people who'd fall into that category. So about 100,000 people would be eligible for surgery just purely based on their BMI, not all the other criteria. But we get we had about 150 funded places for bariatrics, and we were achieving that in 2018, 2019. And then COVID came along and kind of slashed our elective capacity, so we only did about 50 or 60, I think, in the last year, aiming to get it back up again. But it's really quite a small resource. If I think of the 150 we were doing compared to the 100,000 that potentially would have benefited, it's just feels like a drop in the ocean. They've got to be very, very selective about, basically picking the winners, if you like, which seems really hard, and they hate doing that, and they try to sort of almost testing people to make sure that they're going to be motivated enough that if it's worth the public system spending 25 grand on doing their operation or whatever it costs, then that they're going to be able to follow through and make meaningful change in their lives.
Whoa, okay, so fat people have to show they're worthy enough to have the surgery? Some of these hoops seem really arbitrary to me. I mean, let's look at my favourite sport injury comparison. So, say hypothetically, a person were to have a knee operation. They were youngish, loved to get on the grog occasionally, have the odd durry. Again, totally hypothetical. Say said person got the surgery within 3 months of being on the waiting list. They didn't do their exercises and they flaked going to the physio for whatever reason. No one asked. 2 years later, they were back in the operating theatre. This could happen, in theory, 4 times. I'm just asking for a friend. What I mean to say is, unlike sports-related injuries, there appears to be a sense of lifestyle judgment here, especially seeing as it's being used as a justification when really it's about a lack of funding. Public health doctor Gary Jackson says it's a political issue.
It is a political issue, not just in terms of political parties, but in terms of the willingness of the taxpayer to pay funds. Where health gets a bit trapped is that we have to spend money on the emergencies. So if somebody comes in and needs to go on dialysis because their diabetes has wrecked their kidneys, we won't say, oh, we can't afford that dialysis, that's another 60k that we can't afford in our budget, so therefore we'll put them on dialysis. So Counties Manukau has about 650 people on dialysis, so we have about 40% of the dialysis patients in the country are in our facilities. We're only 11% of the population, so it's grossly disproportionate. So that's kind of a rescue kind of thing. So as a health system, we'll always spend money. If you turn up at ED, we'll treat you. If you have a heart attack, we'll treat you. But when I want to, as a public health person, want to go upstream and try to do that prevention work and put in programs so that people lose weight so they don't get diabetes, that's got to be expenditure that's deliberately ring-fenced and pulled out of that emergency system to do that. And it's been really hard. The DHB struggled to actually find, not even the willpower, it's the ability to stop spending that money on the emergency stuff or to moderate it enough that you could then find the money to go upstream.
For the first time, former Counties Manukau District Health Board managed to skim off $5 million from various budgets to create a pilot system that opened in June. Te Maniketua is a weight loss program for people living in Auckland who aren't eligible for the bariatric surgery or who are on the waiting list. The pilot program offers meal replacements for 12 weeks and wraparound services for a year.
7 out of 10 adults in Counties Manukau are either overweight or obese. 1 in 4 Pacifica people and 1 in 6 Māori in the region have a body mass index, so a BMI, of more than 35.
Interestingly, the UK pilot it's based on found 300 people with a BMI of more than 27 and type 2 diabetes maintained an average weight loss of 6 kgs over 5 years. 46% of the group went into diabetes remission within the first year, with a quarter continuing to do so in 5 years. Really, it's not just about weight loss. It's about providing people with quality-free food and access to wraparound services, which tackle underlying health issues that are, remember, associated but not necessarily caused by fatness. And if we are going to say it's about weight loss, then surely using weight caps or the BMI to decide if people are allowed surgery is inappropriate, as they disproportionately discriminate against people on low incomes in Māori and Pacifica. So what does the government think of the barriers for surgery for Māori and Pacifica? Here's former Associate Health Minister and Pacific Peoples Minister, Barbara Edmonds.
Yeah, so I can't provide an insight as to why those caps were put in the first place. There were obviously decisions made before me, but also we have to lean heavily on the clinical advice that obviously ministers receive.
What are your views on weight discrimination? Especially, this is something that has never been in policy from a New Zealand government public health point of view ever. And yet we see the stats overseas, we see the impacts on this population.
Yeah, it's discrimination in any form, whether it's for weight, for weight, race, ethnicity, gender is just not acceptable, full stop.
But if it's being sanctioned with the use of these caps, in the case that you've got, BMI caps, we know that BMI, some would argue, is fundamentally racist. Wouldn't that be discriminatory?
Yeah, so it's something that, again, I can't speak too wider about how the system discriminates in that form. But again, the discrimination, I'm not at all advocating for that discrimination. But if it's something around it prevents a barrier into getting particular help, then that's something that I'd be willing to definitely look at.
To be frank with you, the discrimination in the system really bummed me out. It super highlighted the severity of weight stigma, how slowly the wheels turn when it comes to helping those who want it for whatever reason, and how fraught and complicated these issues are. So finally, seeing as Sophie almost died, people treated her better when she lost weight, and she's had to drastically change her relationship with food, I had to ask,
would you do it again? Yeah, I would, because I still feel like, even though it's been hard and there's been things that I still have to be vigilant about, in doing that and in having lost the weight, I've given myself the best chance of a future for myself too. So even though I think it's absolutely a person's right to decide what they do with their own body and what they choose to do. For me, I chose to do it, and it worked out sort of well in the end. It's just, I guess I feel more privileged on the other side now because I don't have that struggle of having to try and convince people about that because they just accept you, you know? And I don't think it's a good indictment on human beings, really, that, you know, and I still don't get it because I sort of think, well, on the inside, I'm the same person.
I'm Sasha Borissenko, and that was episode 5 of Chewing the Facts. It was written, directed, and produced by me. Executive producer was Teresa Cowie from Connect Content. Post-production and sound design was by Oliver Devlin. Theme music by Thomas Lambert, with special thanks to Andrew Laxon, Ethan Sills, and many more. Follow Chewing the Facts on iHeartRadio or wherever you get your podcasts. We're also on TikTok and Instagram at Chewing the Facts NZ. New episodes are out every Sunday. This podcast was made in collaboration with the New Zealand Herald, with support by New Zealand On Air. In the next episode, I'll be looking more into Aotearoa's health system. Why must you be weighed at the doctor's office? And could doctors, the very people entrusted with your lives, be subject to prejudice?
Everyone is entitled to having our human rights met, having access to that. You know, even if you hate fat people and you think they're gross and you want them to lose weight, the reality is that's not a reason for denying us our human rights.
Thanks for listening. See ya.